Welcome. Thank you so much for joining us for connecting research and practice to combat opioid use disorder among justice-involved populations. My name is Jessica Halsey with the Addiction Policy Forum, and we're part of the Justice Community Opioid Innovation Network, also known as JCOIN. So first off, a little bit about JCOIN. The vision of JCOIN is that every individual involved in the justice system with a substance use disorder should have access to effective treatment. And some of the goals and the main priority areas of JCOIN are to generate new evidence, become a go-to resource for both researchers and practitioners, generate a network of practitioners and researchers who work together nationwide, building capacity to conduct additional research in justice settings, and speeding the translation of science to solutions, really bridging the gap between new research and implementation on the ground. We're very excited today to have two presenters for this session. We have Dr. Ed McGarrell, who's professor at the School of Criminal Justice at Michigan State University. And we also have Dr. James Berry, who's chair of the Department of Behavioral Medicine and Psychiatry and director of addiction services at West Virginia University.
So thank you everybody for paying attention and tuning in to this presentation. My name is Jim Berry and I'm an addiction psychiatrist here at West Virginia University. And for my part of the presentation today is I'm coming at this from the perspective of a treatment provider and try to share some of the experiences I've had with many of my patients who have been connected with a criminal justice institution, and also being able to share some of how I communicate or try to communicate with folks who are working in a criminal justice institution to help them understand what addiction is and what are the needs of our patients. And so with that in mind, I'm going to go through a case study of a patient that typifies some of the challenges we face with the criminal justice population and treating folks who are suffering from substance use disorder. Then go through some of the data on substance use disorders in this population. Then get into the chronic disease model of addiction and outline the benefits of medications for opioid use disorder. So this is a patient that will go by the initials JR. JR is a 27-year-old white male with a 13-year history of IV opioid use and co-occurring cocaine use disorder, alcohol use disorder, and depression. He has a very supportive family, also has a brother who suffers from opioid use disorder. He first presented to our treatment program as part of our addiction intensive outpatient program prior to any legal involvement and was placed on buprenorphine/naloxone for medication to help with his OUD. He was stable on this medicine and this treatment for 6 months and subsequently dropped out of treatment. Following dropping out of treatment, he received multiple charges, including disorderly conduct, drug possession, DUI, and auto theft. All of these charges were directly related to his substance use disorder. After completing 7 months in jail, he was released on house arrest and attended drug court, but not allowed to be on agonist medication. He returned to use, he overdosed, and presented to one of our local emergency departments following Narcan rescue and sent immediately back to jail. He served 9 more months in jail and was released on house arrest to a sober living facility. He was stable on an antidepressant in jail, but was not offered any medications for his opioid use disorder. He was released within he was released and only with 1 week of a prescription for his antidepressant and sadly no follow-up at all. Fortunately, he had a strong relationship with a previous provider within our institution, so he was able to contact this provider and get in to be seen relatively quickly so that he did not have a gap with his antidepressant treatment. However, this would be unusual for others who were not already connected and had a good relationship with our care. which is one of the challenges because many people who are leaving jail or some of the other correctional facilities would be without their medications and could possibly decompensate. So as per his probation, he is not allowed to be on agonist medication, and he has declined naltrexone. He was allowed to be on naltrexone, but did not like it in the past, did not have a good response, did not help him stay away from other substances, and he believed it affected his mood as well. Is currently living at a sober living home and enrolled in an intensive outpatient program at a local behavioral health center, but we don't know how he's doing now since he's no longer in our care. But what this case does is it certainly illustrates a number of the challenges that we see many of our patients facing who are being forced off their medication or not offered evidence-based medications for opioid use disorder, and then the also transitions of care problem where people leave facilities and are not getting in a timely manner for their behavioral health follow-up. As I am certain everyone who is attending to this webinar is aware, that we have had a significant epidemic well before we have had this viral COVID epidemic and pandemic, and that's been an overdose epidemic. Overdose is the leading cause of injury, death in the United States. As of May of 2020, there were over 81,000 overdose deaths, and by all accounts, that number has increased. I think the latest estimate was about 83,000 in 2020, and the numbers are still being counted. But every year, for most of the last 20 years, we continue to increase the record for the number of deaths due to overdose. There was some positive signs in 2017, 2018, and possible 2019 that maybe we saw some plateau, but certainly 2020 and 2021 have gone in the wrong direction again. 38% increase in synthetic opioids. And when we're looking at the overdose epidemic over the last couple of decades, some consider it to be in 3 waves, where the first wave was initiated by the prescription pain pill problem, and followed by the heroin problem, and then followed by the synthetic opioid problems such as fentanyl. And then of course, even more recently, we're seeing a lot of deaths attributed to stimulants like methamphetamine. So between 1999 and 2017, over 700,000 deaths have occurred, the majority of which have included opioids. Sadly, my state of West Virginia has led the country in deaths due to drug overdose, and has done so consistently throughout this epidemic, and 61 per 100,000 in 2020, which is a 22% jump from 2019. So drug overdose is also the leading cause of death among former inmates. And this is a graph that demonstrates how particularly risky it is within the first 2 weeks of release from a correctional facility. And so you can see the 12.7 times greater risk of death within those first 2 weeks. So that first 2 week window is critical in trying to establish linkage to treatment. So a 2007-2009 report from the Bureau of Justice Statistics reported that almost 60% of state prisoners and 63% of sentenced jail inmates met criteria for a substance use disorder. About 15% met criteria for an opioid use disorder. 28% of prisoners and 22% of jail inmates participated in a drug treatment program. Most correctional systems do not offer any medications to incarcerated individuals with OUD, nor do they provide referral to treatment upon release. This has gotten better over the last few years, but we still have a way to go. 4.6% of justice referred clients received agonist treatment compared to 40% of those referred by other sources. Of all criminal justice settings, courts and diversionary programs are least likely to refer people to treatment with methadone or buprenorphine. So an opportunity is being missed to promote effective evidence-based care for these justice-involved people who are seeking OUD treatment. And we know that there is a significant treatment capacity gap in our country of at least 1 million people where there is the capacity for buprenorphine or methadone treatment and the actual need that's out there, and recognizing that those who are in the criminal justice population are at great risk and are at great need, and whatever we can do to expand access to treatment, we need to figure that out. For drug courts, one study found that 56% of drug courts refer to treatment programs that offer at least one of the 3 FDA-approved medications for opioid use disorder. However, many require these medications to be used only short-term to treat opioid withdrawal. And this is not consistent with the evidence base for the most effective treatment strategy for opioid use disorder, which is really seeing this as a problem of a chronic disease nature that requires long-term treatment, and that has the best outcomes. Which leads me to how I usually refer to addiction and talking with many of those who are in the courts and probation officers, child protective services workers, whenever I have opportunity to share and educate, trying to help folks to understand that, listen, this is a chronic health problem. This is a chronic disease that manifests and is caused by 3 basic domains of the biologic, the social, and the psychological. And so what we want to be able to do is try to really appreciate the factors that have contributed in each of those domains, and then target our treatments to each of those domains as well. So using diabetes type 2 as a good example of a chronic disease, we know that from a biological standpoint that there is an impairment in insulin secretion and also end organ insulin response that has a very strong genetic constitution of why somebody would be at risk for this. However, we also know that for those who grow up in a family and a community where exercise is not well promoted, rather they live in a very sedentary lifestyle or culture, and where diet is also not something that's considered of great importance as well, that they are more likely and at risk to develop diabetes and have consequences due to that. And same thing from a psychological standpoint. We also know that during periods of heightened stress, anxiety, and depression, it affects the body's ability to truly secrete and process insulin and glucose metabolism. And this also creates problems with diabetes. So as an example of a chronic disease, and when you look at substance use disorder or addiction, we also know that from a genetic standpoint, there are strong genetic predispositions that puts one at risk for substance use disorder prior to any choices that they have made. And we also know that there are strong social factors that contribute to the development and manifestation of SUD as well. So if you live in a home where there is a lot of substance use, or you have a lot of peer groups where there is a lot of substance use and it's considered a normal thing to do, you're certainly more likely to engage in those activities. Also, if you live in a home where there is a high degree of abuse or trauma, that's also a big risk factor for developing addiction. And I'm sure many of you are aware of the high rates of correlation and association between adverse childhood experiences and development of many chronic diseases, including addiction. And then also psychologically, we know that if you are suffering from depression, anxiety, or other severe psychiatric disorders like PTSD or bipolar disorder, then you're certainly going to be more at risk to engaging in substances and progressing to unhealthy substance use to the point where it can be really negatively impacting your life. And so these are all things that we need to consider. And so when you're looking at treatment models and how to go about addressing these treatments, then from a biological standpoint, we have medications that are available for addiction that have been evidence-based and useful. We have also social determinants and recommendations to include as part of your treatment program, such as attending peer support groups, mutual help groups, such as Alcoholics Anonymous and Narcotics Anonymous. There's a lot of data that supports using these programs to help. And then also from a psychological standpoint, there's a number of evidence-based psychotherapies that have demonstrated efficacy in helping somebody really work through and stay healthy through their addictions, such as cognitive behavioral therapy, motivational interviewing, contingency management. So there are a number of these, and the best treatments really try to incorporate all of these domains in helping one get better. And what I try to help anybody who's listening understand is with any chronic disease, we have really two main goals that we're trying to accomplish. The first main goal is to keep the person alive, and that should be self-evident. But whatever we can do, whatever works to keep the person alive another day, those are the areas and things that we really need to prioritize. And then second, what can we do to increase the quality of life for somebody who is suffering from a chronic disease? And so when we are considering various options and what is possibly on the table regarding our patients or those people who are going through the criminal justice system who have an SUD, prioritizing what we can do to keep the person alive and increase their quality of life. And which brings me to medications for opioid use disorder. It's very clear that these medications save lives. And the mortality risk during and after MOUD, this was a study that was out a couple of years ago, a systematic review, meta-analysis, that for those treated with buprenorphine, that these medications helped reduce overdose mortality by 3 times and all-cause mortality by 2 times. We also see for medications such as methadone and buprenorphine that the medication use was associated with a 38% reduction in overdose and a 37% reduction in all-cause mortality based on another meta-analysis. And then a great study that came out last year in 2020 by Sarah Wakeman, which looked at over 40,000 people and compartmentalized whether they went into treatment, whether they got detox, whether they had intensive behavioral health services or buprenorphine or methadone. Naltrexone or non-intensive behavioral health services. It was very clear from this study that there was a 76% reduction in overdoses at 3 months for those who were offered buprenorphine and methadone, and 60% at a year. And also importantly, especially when discussing this with healthcare systems and also correctional facilities regarding the cost, a 30% reduction in acute care utilization at 3 months and 26% at a year. So why MOUD? Well, because it's clear that it decreases overdose rates. And this is a nice graph early on that demonstrate when a community had greater access to buprenorphine and methadone, that the overdose rates declined of heroin. This is a nice study that that's a good illustration that came out of Norway that looked at patients who were in methadone maintenance programs and criminal convictions. And you could see that those who were in pre-treatment had higher rates of criminal activity. As they were getting into treatment, that criminal activity went down, criminal convictions stayed low while they were in treatment. As they were transitioning out of treatment, the criminal convictions started increasing again until they got back into treatment, and then they went back down. Also, one of the important factors that we need to consider from a public health standpoint is the rate of infectious diseases that are associated with ongoing IV drug use. And so we do know that those folks who are offered medications for opioid use disorder, there is a decrease in the rate of HIV and hepatitis C, and also incidence of severe infections such as endocarditis or osteomyelitis subsequent to IV drug use. We have a huge and growing problem in Appalachia with rising levels of hepatitis C and HIV, especially over the last year and a half, that we need to pay close attention to and try to help resolve, or we are going to face an even greater crisis for years to come. How I describe the medications that are available for opioid use disorder to the lay public or to judges or to lawyers or probation officers or family members for that matter is I use the metaphor of doors, that our brain has a number of these doors that open to a certain degree for opioids. And if somebody has been using opioids such as heroin or pain pills long enough, they're used to having all of these doors wide open, and the chemicals are getting through that initially people were getting high from, and also helping them to feel better. And when those doors are shut, none of the chemicals are getting through. And that's when people go through withdrawal. That's when people crave, et cetera, et cetera. And so using that door metaphor, I'll talk about methadone is on the one end of the spectrum where those doors are wide open, and it's a full agonist medication, and it's letting in those chemicals to help satisfy the cravings, to help people get through withdrawal and maintain health and not being sick from withdrawal. And so we know that with methadone, it can help people sustain long-term sobriety because those cravings are under control and they're not getting sick. On the other end of the spectrum, we have naltrexone, which is a full opioid antagonist or an opioid blocker. And you could say that the doors are completely shut with the naltrexone. None of the chemicals are getting in. And this has been shown to help some with cravings, but also it will minimize the ability for somebody to get high if they were to use another opioid, because those doors are shut and it would be really hard to open with another substance. And in the middle of these two medications is buprenorphine. And buprenorphine is a partial opioid agonist. And what happens in this case is the door opens, but just opens partially. Some of the chemicals are getting through. Enough of the chemicals are getting through so it's satisfying somebody's cravings. And it's also keeping somebody from getting going through withdrawal. One of the big advantages of this partial agonist is there is a ceiling effect to the experience that one can have with higher and higher doses. So it actually plateaus at higher doses and starts acting like a blocker at too high of a dose, and where it actually starts shutting those doors like naltrexone will if it's too high of a dose. This is very advantageous in the sense that it minimizes the likelihood of actually overdosing. It's very hard to overdose on buprenorphine. Most of the cases where we do see overdoses on buprenorphine is when there are other drugs in the system and other sedatives like alcohol. Just an overview that I help some of the other folks understand the differences between the medications. So in methadone is the full agonist medicine. Many of the advantages are this is a long-lasting medication, so you could go one place and get your dose for the day and be satisfied for that day, 24 hours. It's got decades of evidence behind it. We've got the most evidence and the longest evidence to prove the effectiveness and the safety of methadone than any other medication for opioid use disorder. It also helps with pain, and that is a common problem with people who are suffering from addiction. And then some of the problems with, or some of the cons that are associated with methadone, it can be diverted. Not so much through the opioid treatment programs, but most of the, because you have to go there and get an actual daily dose until you've demonstrated a good amount of time of being able to go home with take-home doses. Most of the methadone that's been diverted is through other means like primary care providers, et cetera, and being prescribed for chronic pain. It's rather inconvenient because you have to go somewhere every day and find an opioid treatment program, a methadone clinic that can serve you. It is lethal in overdose. As a full agonist, that is a risk factor for methadone. And then if you were to stop it, of course, you would go through withdrawal. And unfortunately, there's been a lot of stigma regarding agonist treatments such as methadone. Buprenorphine as a partial agonist, some of the pros, one of the big advantages, I should say, about buprenorphine is that it can be prescribed in your doctor's office the way any other medication can be prescribed. And so it's much more convenient. There's less risk of an overdose, as already discussed, less risk of IV drug use. It also is another medicine that helps with pain. And then some of the cons that this is a potentially diverted medication. You will go through withdrawal if you would stop buprenorphine abruptly, and there is also a stigma associated with buprenorphine as well. With naltrexone as the antagonist, it is not diverted. You never have to worry as a physician whether the medication you're being prescribed with the naltrexone is going to be bought and sold on the streets. There is no risk of overdose with naltrexone since it's a full opioid blocker. Some of the problems with it is, number one, initiating naltrexone. That's a tricky business, and you have to make sure that somebody is through their withdrawal and from their full opioids or their partial opioids before you start it, and that can be a challenge. And then keeping people on it is a problem from a compliance standpoint. Also, it does not help with pain. But bottom line, it really comes down to patient's preference and experience with any of these medications as far as which is going to make the most sense for which particular patient. And most patients prefer methadone or buprenorphine because of the agonist effect and how that's helping with their cravings. There is diversion and past use of prescribed medications that should be considered. It is important to note, though, that it's been pretty consistent with the evidence and my experience in treating patients that most of the buprenorphine that has been diverted or is being diverted is because people can't get into treatment. And so a lot of my patients come having already used buprenorphine on the streets, and they're using that so they are not using heroin or at risk of using fentanyl, and they understand how risky that is, so they're trying to use something like buprenorphine to keep them safer and hold them over. Now also there is two formulations of injectable buprenorphine that one has been available for a while, and another one is going to be available and is available in some limited amounts currently. That could be an option if one is worried about injecting buprenorphine. So they could get a injection with this buprenorphine and not worry about having the medication in their hands that could be used for injecting. So summary of the MOED outcomes: treatment using agonist medication is estimated to reduce mortality by up to 50%. Treatment with methadone or buprenorphine is also associated with lower rates of other opioid use, improved social functioning, decreased injection drug use, better quality of life, and reduced levels of criminality. There is some evidence that compared with the placebo, the extended release naltrexone, and naltrexone I didn't mention, but most of you are probably aware that naltrexone comes in both an oral form and a long-acting injectable form. The oral form has had historical problems with compliance, and the injectable form was an attempt and a successful attempt to improve the likelihood of compliance as far as just getting a once a month injection as opposed to just getting taking a medication every day. So it is associated with reduced opioid use, but more rigorous studies are still needed. which getting back to the original case with JR is one of the things to be aware of is the American Disabilities Act, which prohibits discrimination by state and local governments. And in order for this to happen, an individual must prove that they were discriminated against, that they do have a disability, is, quote, otherwise qualified under, unquote, to participate in or receive the public entities, benefits, including services, programs, or activities, was excluded from this participation in or denied the benefits or was otherwise discriminated against because of a disability. And from the definition of disability in the American Disabilities Act, it includes a physical or mental impairment, and drug addiction, quote unquote, drug addiction and alcoholism in the act is the language that's used, would be a physical or mental impairment. And so a blanket prohibition against MOUD is a violation of this American Disabilities Act. So policies that are just blanket policies that really come down to the idea that you are substituting one addiction for another by using these agonist treatments, that can be considered discrimination. You really have to nail down into individual patients and their treatment plans and what's needed in order to provide effective treatment and do so in a way that's not discriminatory. I would draw your attention for those who are not aware. I would suspect that many of you are, the Legal Action Center. The Legal Action Center actually worked with ATOD a couple years ago to develop a comprehensive report regarding using medications in the criminal justice setting. And it's a very, very good report that outlines the evidence and the reasons why. And there is a toolkit, and this is the website for this toolkit that also has a number of great resources such as sample treatment provider letters that you as a provider could use for patients to advocate on their behalf. There's an attorney's guide for clients involved in these issues. There's also cases that are discussed involving discrimination and those outcomes of those cases. There's recommended strategies for drug courts, and then also letters that people can use to help persuade the courts to allow people to use this evidence-based treatment. So with that, I thank you for tuning in and look forward to the time where we're able to entertain questions and look forward to the rest of the presentation. Thank you.
Well, welcome everyone. It's a pleasure to be here. James has very effectively reminded us of why we are here and why this is such an important topic. He's also provided a link to evidence-based practice that we can build upon to achieve those goals that he talked about of, first of all, keeping people alive, as well as improving their quality of life. And I think if we can achieve those first two goals, then we can think about a whole variety of benefits to people, to families, to communities, and even at a societal level. So I really appreciate following his presentation and the perspective that he brings grounded in practice. I come to this presentation from the perspective of a researcher who works in partnership with justice agencies. Thus, our session really reflects this theme of connecting research and practice. It's a pleasure to be here at the ATOD conference and to have this opportunity to talk about the role of research partnerships and the integration of research and treatment programs and justice agencies seeking to improve the response to substance use disorder. I'll build on Jessica's introduction to JCOIN, as well as Dr. Berry's discussion from the perspective of a behavioral health physician involved in patient care and treatment. For many in the ATOD community, this emphasis on research integration might seem like old hat. You may be part of a university, you may have a formal relationship with the university, you may have researchers on staff or work with researchers. In the justice system world that I come from, the formal relationships with researchers are less common, although they are becoming more common today than was the case in the past. we found it useful to think about developing research partnerships in a broader definition of the research role than just evaluation. I will also talk about an action research framework to guide the research partnerships, as well as some suggestions for building strong researcher-practitioner partnerships. Finally, I'll come back to JCOIN and talk about some of the training and technical assistance resources that you may find of interest. Let's take a second to ask these questions. Have you been involved in a researcher-practitioner partnership? Would you describe it as a partnership, as a successful partnership or an unsuccessful partnership? And is there anything you do differently in the future? I think many of us have had varying experiences with these types of partnerships. And so part of what I want to talk about is to ground us kind of in a common understanding of what the partnerships involve, what we might hope to get out of these partnerships, and maybe some tips and lessons learned in terms of maximizing the benefit of these partnerships as we move forward. As I noted, those of you in the behavioral health community may have long-standing engagement with research and researchers. For those of you in the justice system, there's been an evolution over the last 25 years where researcher-practitioner partnerships have become more common. The Bureau of Justice Assistance, the National Institute of Justice, and the broader Office of Justice programs have been encouraging researcher-practitioner projects. The list you see on this slide is a sample of some of the notable initiatives that have involved these types of researcher-practitioner partnerships. Some of the tools that have been developed to address substance use disorder have been produced by researcher-practitioner partnerships. And similarly, we've developed other evidence-based approaches to violence prevention through such collaborations. There are different approaches to research and different aspects to research that relate to the research partnership. Within the research community, many researchers first think of basic research. This is science that just seeks to generate new knowledge. Advances in our understanding of the brain and how substance use affects the brain is this type of basic research. And I think Dr. Berry gave us some nice examples of what we've learned about substance use and its impact on the brain, its physiological and psychological effects in his presentation. Many of us also think of evaluation when we think of research. Evaluation researchers typically look at a treatment intervention or a program and ask, did the treatment have its desired effect? If not, why not? And also, were there unintended consequences? The findings from evaluation research generate what we refer to as evidence-based practices. Typically, this is where we have findings from multiple systematic studies that produce consistent findings of desired treatment effects. And again, Dr. Berry reviewed some of the important evidence that's emerged from research on substance use. Action research builds on these other types of research, but is particularly appropriate for community engaged research. Action research is research that's focused on solving problems. Thus, in trying to address the issue of substance use disorder in a justice-involved population, we might ask questions like, whether risk and needs assessment provides a more effective way to link clients to appropriate treatment. We might also find that in order to effectively implement those treatments, that we need to consider staff training and support. Essentially, practitioners and researchers work together to address the problem and continually respond or improve the response to justice-involved people. Given these different models of research, it's important to realize that there are different types of researchers and different approaches to research. Choosing the right partner puts a team on the path to success. Traditionally, research saw itself as detached from practice in order to maintain an objective perspective or a neutral stance toward the problem or the policy that was being studied. When I advocate for a research partnership following an action research model, I'm being intentional in advocating for an engaged partnership where practitioners and researchers work together to solve problems. In action research, the researcher seeks to be involved in the problem-solving process. The research does not focus or does not seek the primary purpose of theory building or methodological development, but rather to improve the lives of everyday citizens, families, and communities. As Jessica noted at the outset, our collaboration involves NIDA's JCOIN initiative. Ultimately, JCOIN involves and supports all of these types of research. Basic research is occurring throughout JCOIN's network of research hubs, as well as in the wide variety of NIH-supported research. My guess is that many of you are seeking to identify and implement evidence-based practices. When you implement and evaluate evidence-based practices or evidence-informed innovations, you may help contribute to the evidence base of what works. Finally, many of you may benefit from this action research partnership that I've been discussing, where the collaboration is really one in which researchers and practitioners work together to try to figure it out. As stated previously, the research partnerships can help assess the local nature or local SUD issues, identify evidence-based and evidence-informed practices, support their effective implementation, and evaluate the effect of that implementation. The specific emphasis across these four dimensions may vary from local agency to local agency, but we're convinced that integrating research approaches into your state and local efforts to address SUD will build capacity and ultimately improve public health and safety. Finally, let me summarize the role of the research partnership in terms of what we refer to as the life cycle of a project or an intervention. For some of you, this may mean the life cycle of a grant. For others, it may mean the life cycle of a new initiative or new strategy that you seek to implement. The research partnership can assist you across all these stages, from initial conceptualization to implementation, and ultimately through evaluation and long-term sustainability. JCOIN promotes the use of the strategic planning throughout the life cycle of strategic interventions and of its grant programs. This involves creating the necessary partnerships to tackle the issues or the problems that are being addressed, and then to systematically analyze the problem. This might involve a particular client group or a recurring systemic issue such as jail overcrowding, or former citizens coming out of institutions and returning to the community. The problem analysis provides the basis for considering the development of evidence-based practices or evidence-informed innovation. Strategic planning processes can also be critical for planning and ensuring effective implementation of those evidence-based strategies that you've decided to implement. Research consistently shows how difficult it is to successfully implement strategies. And thus, JCOIN seeks to foster the development of implementation teams and implementation champions to shepherd programs from idea to actual on-the-ground implementation. And finally, JCOIN promotes accountability through assessment and evaluation, as well as the development of a community of practice, whereby we learn from one another in the continual support for development of innovation and evidence-based practice. In this schematic, we can see both the sequence and the connection among program components. That is, how program activities like forming a team, problem analysis, assessment, and evaluation lead to the problem-solving process in a logical and coherent fashion. At every stage, I would argue that a well-functioning research practitioner partnership can help us achieve the goals and objectives that we hope to accomplish. We use the term partnership intentionally. As in any relationship, we seek a mutually beneficial relationship that fulfills the goals and objectives of all the partners. But as with all relationships, these successful partnerships don't happen automatically. Some of the lessons learned from successful researcher practitioner partnerships are that they involve regular and transparent communication that results in shared expectations. This typically then results or translates into mutual trust. It's also important to remember the different roles of those, for those of us that are involved in these types of partnerships. Professionals in the justice system and behavioral health agencies face day-to-day challenges and responsibilities, resource constraints, and other issues and pressures. They have to make decisions under time constraints and are ultimately responsible to the people, the families, and the communities that they serve. Researchers are under pressure to conduct the highest quality research, and that takes time. Thus, one difference to be considered is the varying time pressures of practice and research. Similarly, it's important to keep in mind that research findings do not tell a professional what to do, but rather they are an additional source of information that can help inform decision-making. Keeping these roles clear is part of creating that shared understanding and mutual respect and trust. You may find it helpful to develop MOUs and data sharing agreements to create shared expectations. If so, this is the type of topic where JCOIN training and technical assistance can help with examples of such MOUs and data sharing agreements. In order to sustain a mutually beneficial partnership, it's good to anticipate the challenges that often arise in justice and behavioral health settings. One of the most common challenges is changes in leadership. I was recently working with a multi-agency team that was involved in a community-based neighborhood revitalization and public safety initiative. Over the last several years, they'd had a change in the mayor's office, 4 different chiefs of police, and with every change in chief, there was a change in the whole leadership structure of the department, and similar changes in some of the other partnering agencies. Thinking about how your partnership will handle those type of leadership changes, as well as changes in law and policy, financial challenges that may emerge, and similar issues, can help the partnership sustain itself over time. Some of the key lessons are not to rely on just 1 or 2 key persons from each of the partnering agencies, but rather to build a broader network of supporters. A key part of this may be to provide training beyond your core part to the broader group that are involved in ultimately driving the program or initiative that you're putting into place. Finally, for those of you involved in evaluations, it's also good to talk about how you're going to share your research findings. Part of building trust may be that the researcher agrees to share findings with other members of the partnership before any broader dissemination of those findings would occur. Seeing negative findings emerge in the local press before there's been internal discussion of those findings does not bode well for a long-term partnership. Similarly, the way in which we present findings can be important. What might at first appear to be a negative evaluation finding can take on a different meaning if what we really find is that there were problems in program implementation and that our sharing of those findings includes suggestions for how we might strengthen the implementation of that treatment intervention. With this background on researcher-practitioner partnerships, I'd like to next turn to some of the resources that are provided through JCOIN that can support the integration of research into your agencies and into these partnerships. Within the JCOIN, there's a Coordination and Translation Center that's known as the CTC. Within the CTC, there's a series of complementary cores that work together to support justice and behavioral health partners. I'm part of one of the cores that's referred to as a community stakeholder core. As the slide indicates, our mission is to provide training and technical assistance related to the integration of research to build capacity within justice and behavioral health agencies for the effective implementation of evidence-based practices to address issues of substance use disorder. Ultimately, we hope that we can support your efforts to increase access to effective treatment for justice-involved people. The CTC provides a mechanism to tap into the wide array of resources of JCOIN and the many NIDA partners who are involved in both practice and research. One of the great things about Jessica and her dissemination and stakeholder core is that they work with a very vibrant group of justice and behavioral health leaders and professional associations that help ground the research work in practice. We believe that the result is both research-informed practice and practice-informed research. We believe that the various types of training and technical assistance resources that you see listed on this slide have this type of grounding in both research and practice. As Jessica noted, the JCOIN-CTC is developing a very extensive library of courses, webinars, and related resources. Here, I've listed 4 courses that are being developed by the Community Stakeholder Core to provide support for the topics that we've been discussing here today. I encourage you to become part of the JCOIN community of practice and take advantage of these and the other resources that are available through JCOIN. You can learn more about JCOIN training and technical assistance at the web link you see displayed. Also, feel free to directly reach out to my colleague, Heather Perez, who coordinates our training and technical assistance activities. Finally, as I noted, I do strongly encourage you to join become part of the JCOIN community of practice. You'll have free access to the types of resources that we've been discussing. It does require registration, but it's a quick and easy process. I appreciate the opportunity to be able to talk about research partnerships and JCOIN training and technical assistance. Don't hesitate to reach out to us, and I look forward to the opportunity to address questions in the Q&A session. Thank you.